Welcome to our first video on nervous system tumors. Let's begin. We'll discuss Schwannoma, Medulloblastoma, and Hemangioblastoma. We will discuss definition, clinical findings, histology, imaging, and prognosis of Schwannoma. Schwannomas are benign tumors derived from Schwann cells. Cranial nerve 5 and 8 may be involved, as well as spinal nerve roots and peripheral nerves. Most commonly occurs in the 2nd to 5th decade of life. It appears more frequently on the extremities with a predilection to the upper extremities, followed by the head and neck area, including the oral cavity, orbit, and salivary glands. It can occur in familiar tumor syndromes such as neurofibromatosis type 2. On neurofibromatosis type 2, there is a loss of function of the tumor suppressor gene Merlin, also called Schwannomin. This causes a direct genetic change involving the NF2 gene on chromosome 22, or secondarily to Merlin inactivation. Acoustic neuromas are schwannomas of the 8th cranial nerve. The majority are located in the cerebellopontine angle. On gross examination, they are seen as encapsulated tumors, usually unilateral. On microscopic view, there are alternating dark and light areas. Let's move on to clinical findings. Schwannomas are associated with neurofibromatosis type 2, usually bilateral tumors. There is tinnitus or ringing in ear. A sensorineural deafness is seen as well. There can also be sensory changes in cranial nerve 5 distribution due to the tumor impingement on the trigeminal nerve, seen in a trigeminal schwannoma. Trigeminal schwannomas are rare but are the second most common schwannoma after vestibular schwannomas. Now let's move on to histology. In schwannomas, there are two types of histologic findings: Antony A, which are the interlacing bundles of elongated cells with palisading nuclei, and Antony B, which are looser and less amount of cellular pattern than Antony A. There are nuclear palisading around fibrillary process called Verroque bodies, and these are often seen in cellular areas. The tumor cells have a poorly defined cytoplasm and dense chromatin. Here we have two images. The image on the left is Antony A pattern. Remember, these show interlacing cell bundles with palisading nuclei. And the image on the right is Antony B, which are looser and less cellular. Now let's discuss imaging. On radiologic examination, we typically see well-defined masses which displace nearby structures without directly invading other tissues. Schwannomas typically involve the cranial nerve 8 at the cerebellopontine angle. This presents as a loss of hearing and tinnitus. Lastly, let's talk about the prognosis. There is a good prognosis, but surgery is required. The chance of malignant transformation is extremely rare. A sudden progressive increase in size is an alarming feature. Now let's continue with medulloblastoma. We'll cover definition, clinical features, diagnosis, and treatment. Medulloblastoma is a malignant small cell tumor, and it is primitive neuroectodermal tumor. It primarily occurs in children. Now let's continue to describe the clinical features. Medulloblastomas often present as midline masses in the roof of the fourth ventricle, accompanied by mass effect and hydrocephalus. Arise in cerebellum, specifically from the external granular cell layer of the cerebellum, resulting in ataxia and a wide-based gait. They often seed the neuraxis and invade the fourth ventricle. Seeding means metastasis, and neuraxis refers to the axis of the central nervous system. This malignant spread through the CNS usually happens through cerebrospinal fluid pathways. Now let's continue to describe the diagnosis. Histologic characteristics include sheets of closely packed small blue cells with scant cytoplasm arranged in a rosette or perivascular pseudo-rosette pattern, also called homorite rosette. These rosettes are malignant cells and arranged around a blood vessel rather than a lumen. Notice how these neoplastic cells are arranged around small blood vessels. This arrangement is referred to as a homorite rosette. Medulloblastomas are seen as midline masses in the roof of the fourth ventricle, with associated mass effect. Notice how they are hyperdense, meaning there is more attenuation compared to the tissue surrounding the mass. Let's continue with treatment. Medulloblastomas are radiosensitive tumors, and radiation therapy is the single most effective post-operative treatment, with radiation delivered to the total craniospinal axis. Since medulloblastomas are majorly stage 4 tumors, they have a poor prognosis. For pediatric patients, localized radiotherapy can result in a good prognosis. Some patients have a p53 mutation seen in Lee-Fraumeni syndrome, and these have the worst prognosis. Alright, now let's do a flash quiz. A 21-year-old male with known medulloblastoma undergoes a screening colonoscopy due to a family history of colon cancer. The colonoscopy reveals hundreds of polyps within the colon. What is the likely underlying diagnosis? The patient in question likely has Turco syndrome. This syndrome is characterized by familial adenomatous polyposis, cafe au lait spots, and CNS tumors such as medulloblastoma. As such, this question serves to remind you that medulloblastomas can be associated with other pathologies in the pediatric population. Let's move on to hemangioblastoma. We'll cover definition, clinical features, and diagnosis of hemangioblastoma. Hemangioblastomas occur most frequently in the posterior fossa. In von Hippel-Lindau disease, due to a VHL mutation, there is an increased risk of developing hemangioblastomas, bilateral renal cell carcinoma, and pheochromocytomas. Let's move on to describing the clinical features. The presentation of hemangioblastomas is going to depend on the location and growth of the mass. If it's located on the cerebellum, it will show signs such as ataxia and discoordination or mass effect symptoms. Patients with VHL disease can show ocular or systemic symptoms because of other organs and systems are involved. Let's move on to describing the diagnosis. Histologically, hemangioblastomas show a proliferation of capillaries with a disorganized arrangement, thin walls lined by vacuoles containing PAS-positive lipid. These cells are separated by larger pleomorphic stromal cells. Here we see proliferation of thin-walled blood vessels and cells with lipid vacuoles. These findings are very characteristic for hemangioblastomas. Let's take a look at what these tumors look like on imaging studies. On imaging, hemangioblastomas typically show up as sharply demarcated cystic masses, as pointed out by the white arrow. Take a look at this small, non-enhancing mural nodule, surrounded by the enhancing cystic area. Now it's time for a flash quiz. If a clinician diagnoses a hemangioblastoma in a patient with von Hippel-Lindau syndrome, what other malignancies would warrant diagnostic consideration? This question serves as a reminder that patients with von Hippel-Lindau syndrome is a multisystem tumor predisposition syndrome characterized by benign and malignant tumors, including central nervous system and retinal hemangioblastomas, clear cell renal cell carcinoma, and pheochromocytoma. A useful mnemonic to remember about von Hippel-Lindau is HARP. H stands for hemangioblastoma, A stands for angiomatosis, R stands for renal cell carcinoma, and P stands for pheochromocytoma. And that concludes this section.